What else do you do from a hospitality standpoint? Just odds and ends, high points, anything that pops into your head?
Right.
Just to make the comfortable.
We talked about our blanket warmer.
Yeah.
One of the signature stories from my seminars is the idea of a smoothie.
A smoothie?
A juice smoothie, a frozen smoothie drink.
In the office?
In the office.
See, now you can feel my reaction, can't you? I'm like, holy cow.
What flavor do I get?
I want blueberry.
We do most of our major procedures in the morning when I'm fresh. I've had doctors at seminars say, well, my patients won't come in. Well, you could go tell an orthopedic surgeon, I want you to do my knee Friday afternoon, and they say, I do knees on Tuesday mornings. That's when you're...
And we say,
I'll be there. Or you go get someone else. So the whole smoothie concept, I'll ask a patient, we do our procedure in the morning, I'll say, Mark, did you have breakfast? Almost always, what's Mark going to say?
No.
No, I was too nervous, I didn't have time, I didn't want to hurl with the impression.
I like the hurl with the impression one, that's good.
Gently said. And I'll say, well, do you like smoothies? I like guava gulp, what's your favorite? And they'll say, strawberry surprise. And I'll say, in that, I haven't had that before. And we go on working, we pass a note to the business team, who they jump in their car, run to the juice shop a mile from the office, bring back a large smoothie. Once we pull the impression out or finish the procedure with the patient, we'll sit them up and say, here's a gift from us to you.
No kidding.
When we make our care phone calls at night, that's another added benefit that we do. Again, I've had doctors say, well, I don't have time to do that, and I'll argue that the staff can program in the numbers on the cell phone. When you're riding home, you can go ahead and do that. I'll make the care phone calls at night, Mark.
Staff could program, I love it.
Your business team could just take your cell phone and say...
Punch in those 6 numbers you're going to call, or the 2 numbers you're going to call, and then you just look at it and go, that's Bob, that's...
It's as easy as that.
Good thinking.
I make the care phone call at night, and I'll say, Mark Hyman, just want to see, are you still mad at me after our dental work today? And what does Mark say?
I'm not mad at you at all.
And Mark says, man, doctor, thank you for the way you marginated. Thanks for the way you adjusted my CRCO skid, or thanks for the smoothie.
Thanks for the smoothies.
Chris Sager says 97% of our patients have no clue what we're doing for them. Technically, it's the experience. So what type of experience are you going to give to your practice, to your patients? What type of wow? Injection technique, I use the Ligajet. I've not given a mandibular block since 1986.
No kidding.
When I said that, I get one of 2 reactions.
No kidding is one of them.
No kidding is one. One is I've had people in seminars say, well, you must just work on maxillary teeth. And then Dr. Becker from Pankey, my hero and mentor, said, well, weren't you any good at it? So I appreciated that. Love to you, Erwin. When I started the practice in '86, I wanted to be distinctive. I was 26, 27 years old, still had my hair.
You're still 26, 27 years old.
And I wanted patients were saying, are you old enough to do this to me? Now,
I grew the mustache, remember?
I got wrinkly. Anyway, I wanted to do something that was distinctive and a special wow for them.
No blocks.
And I hated having my tongue numb when I'd had a block.
I'm with you on that.
And so I started working with the Ligajet 30 extra short needle, big GABA topical, take the mirror tip, blanch the tissue, round it in the buccal vestibule, raise a little wheel, rub it in, go mesial, go distal, rub it in, go up to the papillae, bump both of those, then go through to the lingual, bend the needle like you're not supposed to, touch the lingual again with a drop. It takes 1 minute, 99% of the time they're numb.
No kidding. Rather than going down intraligamentally.
Right.
Wow.
So I dance around the tooth and it works 99%.
Because I've done that and watched the molar like kind of puff up out of the side. No, I'm just joking.
Then you get to do an occlusal adjustment, which is great. So we use an anesthetic warmer to heat the anesthetic. We use that 30 extra short needle. We go very slow with the local. We use a GABA topical. And I try to ask the patients, I inform them and empower them the minute, anytime you want me to stop, raise your hand, I'll stop.
Not even one mandibular block?
I haven't not given a single mandibular block in 20 years.
Okay, go ahead.
So that's the truth. The camera we talked about as a before, during, and after for the dental insurance issue, but also when the patients leave your office, what do they leave with? Your black and white business card with the dental caduceus or the extracted tooth on it that says Mark Murphy, DDS, TWA, KLM, or an intraoral camera photo of the before, during, and after.
And a smoothie stain on the
And the smoothie stain, but they walk out of there with a color photo, going back to work saying, look what my doctor did. Now, we worked with CERAC for almost 10 years now. The first couple years I had CERAC, I had patients insisting they had to have another visit. Or friends of theirs saying, well,
when are you going back for that?
Yeah, but you have to come back for a second visit. And I'm like, no, you don't.
Wow.
So that was a pretty wow.
And they go home and tell a story about that. That's
and
one of the benefits
or go back
of
to work with the color photo and show their coworkers what you did in one visit.
Now, I can just imagine the impact of them going back and their coworkers saying, and so you're all numb and everything like that? No.
My tongue's not numb. I got a smoothie.
A warm blanket.
I was warmed. We have headphones. We have.
I want a crown done now.
Come on, I can do that. We have a couple hundred CDs in the office. We hand
couple hundred.
Yes. Wow. And we hand patients a music menu and say, here's a music menu, pick what you'd like, or you can listen to satellite radio that we have in the office. So the patients come in, they're seated, they're warm, they have dark safety glasses so the bright lights don't bother them, they have a very gentle injection, they have headphones on to listen to. The team is well informed what the procedure is. We're set up, we have trays so the procedures go promptly. They get numb quickly, we work efficiently and effectively as a team. So they ought to get in and get out promptly. You know, I heard an expression from one of my favorite professors at the dental school at Chapel Hill, just because you're slow doesn't mean you're good. You think about that. I think patients don't want a 2.5-hour crown prep.
I think that you're right. I think that's a paradigm in our mind that it has to take long.
And I had another professor say, you know, God just didn't make that much enamel. What are you doing? Why are you taking 2 hours to prepare one tooth?
And so you get an incredible response, for example, to something like CEREC.
Well, we work with an electric handpiece. We cut efficiently. They're numb. We're finished. We have the before and after photo, and then I make the phone call at night, and that's kind of the bow on the package.
Wow.
We talked about that new patient experience. Once the new patient leaves the office the next day, they get a handwritten note from the team and I, one nice impressionist stationery, where we have thanked them for choosing us as their doctors and teams. Whoever sent them, another dentist that referred them to me or someone in the community. I used to write a lot more of those. With the internet, it's less than I did.
So now you flop some emails like you and I do back and forth all
we
the time.
Do that, but I'll try to send a note to whoever referred me the patient and thank them.
You still call once in a while, though. I like that. That's a personal touch.
I miss the human contact. I think, again, when you look at your patient population, you certainly need to tailor it to who you serve.
Absolutely.
But
right.
Our generation, the baby boomers, we don't like answer machines and press 1 if you want this, press 2. That offends me. With my teammates, they're fabulous on the phone, and I love that most of our phone calls are answered by a live voice. Mm-hmm. And I think it's important to look at that, and again, it's part of the overall package of telling patients that they belong and that they're important to you and that you care.
Well, Mark, I think this is outstanding. You know, I think, too, this idea of tailoring it to the patients, really, I could say the same thing about the types of things that we're talking about today. The practice management issues, the hospitality, the customer relationship management issues, the warm towels, the smoothies. Mark, you're not saying everybody needs to go out and do that. You're saying, just like you would say about custom tailoring to your patient, for everyone watching this and every team to sit down and on their own to kind of get a handle on what's right for you.
Exactly.
What's comfortable for you? What are your circumstances? What's your temperament? What are your objectives? What image is your office?
Exactly.
To portray.
A word that Pankey Institute taught me was appropriate.
Absolutely.
And what's appropriate for you at this point in your career. And it's okay to stretch and grow and try to raise your game. And I think, again, many of us have limiting beliefs that just don't have to be there. Many of us were taught in dental school, here's the way it has to be done. Well, I started dental school 26 years ago. I don't want to do 26-year-old dentistry. The principles of quality don't change, but think about how dentistry was done. You take a Midwest handpiece with no fiber optic, you drill a big hole in the top of the tooth, put 2 pounds of dical, a gallon of copolite, and thumb in a tight amalgam, right? Dr. Murphy says that's what I did yesterday. Not a problem, Mark, but I understand that. Can we do better than that in dentistry?
I hope so.
Yeah, I hope so.
I'm coachable.
And when I see the resistance, I think a lot of it is a self-esteem issue. When I spoke to the rising seniors at the dental school at Chapel Hill last summer, when I was talking about CEREC, the CAD/CAM restorations, a young student raised his hand and said, we were told by a faculty member not to buy a CEREC machine because if we did, we would be tempted to use it. And you want to say, that's just sad. It's sad for our entire profession that educationally we allow that type of limiting belief.
Yeah.
I'm not saying...
Especially at such an impressionable age. We're in our infancy.
One of the horrors...
As dentists.
We are in our infancy, and the challenge is most of the faculty, I think I'm okay to say this, what percentage of faculty nationwide has done a CAD/CAM restoration, would you say? Less than 5%?
Yeah, you know, we've got one of the CEREC specialists coming down to the Institute.
That's dynamite.
December to spend some time talking about that very issue in education.
It's not for every practice. It's not for every tooth.
Correct.
I think perhaps the professor's point was you don't take a facial pit and turn it into a CAD/CAM restoration. That's over-treatment.
Correct.
I'm completely respectful of that.
Absolutely.
That said, if you see on a two-dimensional black and white x-ray that it's just an occlusal amalgam, but you dry the tooth off, use your intraoral camera, and you see that the mesial and distal marginal ridge is cracked through to the dentin, then you're not being honest with the patient, not saying the tooth is vertically cracked. So again, I think, who are we trying to serve? What level of care are we trying to provide?
I think that's excellent. I think the message of appropriateness in all those modalities is very apropos.
Right.
Appreciate it. Well, Mark, I want to thank you very much.
It's been my pleasure. This has been a lot of fun.
It really is.
Would love to do it again sometime.